Good afternoon, everyone. We are excited to have you join the next installment of the Maryland Emergency Preparedness Network COVID-19 webinar series. Today, we're meeting with Dr. Alan Abrams again. He's here for an encore presentation. This time, he'll be talking about caring for older adults with COVID in the home and how to garner community supports. This is me. I'm Dr. Charlene Brown, for those of you who are joining for the first time. I am the CEO and founder of CNA Simulations VR. I am co-planning this webinar series with my colleague Nassim Weisborg and in collaboration with the Maryland National Capital Home Care Association. And I'm a former board member at the Maryland National Capital Home Care Association. The Maryland Emergency Preparedness Network is actually funded by the Maryland's Office of Preparedness and Response. And so we're grateful to the Department of Health for their vision to support this webinar series. They have been so consistent in their support and their vision. And if you'd like to join the Emergency Preparedness Network, it's not just focused on COVID, it's focused on emergency preparedness for home care agencies in Maryland. You can follow the links on your screen to join MINCA, the Maryland's premier home care trade association. You can join EPN, or you can contact me if you're interested in CNA simulations, clinical simulations for nursing assistants. So, upcoming webinars. Well, I used an outdated slide, what do you know? So anyway, I'm just gonna tell you what's coming. So we're all the way down to December 15th. This is a cut and paste. This is what happens when you cut and paste too often. So next on Thursday, Alma Adepagrin, who's a CNA, we'll be talking about caring for the caregiver. She's a CNA and she'll be sharing her perspective. On December 21st, I will be giving a talk on aerosols and COVID, what home care clinicians need to know. And on December 22nd, we're having two pretty inspiring CNAs who formed a talk show for CNAs called Let's Talk CNAs, Wendell Anderson and Angel Jackson. They'll be talking about how to protect your patients and residents and clients when you're not at work. And this talk will be directed to CNAs with an open door for anyone who cares about or is involved with the care of older adults to join. Today's featured presenter is Dr. Alan Abrams. He's a geriatrician with more than 4 decades of experience. The man is a wizard in a nutshell. He was my professor. I can hear him chuckling in the background. He was my attending and professor when I was training to become a physician. He continues on the faculty at Harvard Medical School. He's on the board of directors for Senior Helpers. He's also Senior Helpers geriatric clinical advisor for franchisees around the country. He's the CMO, Chief Medical Officer for Perfect Health. And if we traveled through his more than 40-year career, he's been involved with senior care from so many different angles, it's hard to really summarize them. One of his standout activities was serving as the Chief Medical Officer of Harvard's Beth Israel Deaconess Care Organization. And he has been lauded through Physician of the Year awards. He holds an MPH from Harvard School of Public Health. He holds an MD from NYU School of Medicine. He completed his internal medicine residency at Cambridge Hospital, my alma mater, and did a fellowship in geriatrics at Harvard. Thank you, Dr. Abrams, for joining us again. I'm gonna stop sharing my screen and give you the floor.
Thank you very much, Charlene. So, welcome everybody. The purpose of this conversation for the next 45 minutes is to really talk about all of the ins and outs of trying to care for somebody who actually is an older adult that has COVID and is residing in the community. It could be in a family home, it could be in a senior housing complex, it could be in public housing, private housing, or it could be in some kind of congregate housing, including assisted living facilities, where kind of the ways in which assisted living facilities have addressed active COVID patients has varied across states and across different enterprises. And I'll try to hit on a lot of those things, but I'm going to count on you during the Q&A to actually ask the questions that are most important to you in the work that you do. And I just wondered, Dr. Brown, the last time we did this, we kind of got a little hint of who is in the audience and what their backgrounds were. And I was wondering if we could take a minute, if that was possible to do before we get started here today.
Absolutely, Dr. Abrams. We can ask people who are in attendance to drop a line in the chat about your connection to this topic and what inspired you to join here today, and what your professional background is. So just drop it in the chat. And also at the end, when you can drop your questions in the Q&A section throughout the presentation, and Dr. Abrams will answer questions as he can during and after the presentation. So,
Great.
All right, people are starting
to
provide it in the chat.
Yeah, so I'm seeing some people going to the chat and filling out, their professional roles, and to some degree I can see some of the associated organizations that you're with. But so let's begin the conversation by talking about what seems to be happening. And I do want to say in preamble that, I know that we have just started to immunize the highest risk people in, across the country in multiple states, that each state has its own way of distributing the vaccinations and that are available, and people will need 2 doses. But we also know that for the next several months, and for me, that means from now until at least midsummer, that we're going to be experiencing a lot of people having symptoms and a lot of people testing positive for COVID. The first thing that I wanted to say about COVID and older adults is that we shouldn't forget that even though there's been a lot of headlines about older adults dying at a higher rate than others, that, just remember that, 8 out of 10 older adults who have test positive COVID virus, that they actually survive. And, not everybody survives without any aftermath, but a lot of people, even in their later years, kind of are able to, manage their way through without having to go to a hospital and without needing any really extra treatment. So, I think that's a really important thing to begin with, because I know how scared people get from my own experience, since I'm still in practice doing home-based primary care across Eastern Massachusetts. And I know how frightened families and older adults get when they begin to have symptoms and a COVID test is positive. But the first thing that should be on the order list is reassurance that, until proven otherwise, that most people get through. Obviously, people who have a number of comorbidities, which we'll go through a little bit later, are at higher risk for having more severe disease and having difficulties. But I wanted to begin by saying, what do we do in my home-based primary care practice when somebody reports that they're having symptoms, and aside from getting the test done, and what we actually do to begin with. So how do we advise people? So I think the first thing is that probably the most common symptom that people get is a fever of some sort. And one of the things that happens whenever any of us get a fever and muscle aches and joint aches that come with that fever is that we tend to not feel like eating or drinking. And with COVID, obviously, people also can lose their taste. And that could be absolute or relatively speaking. And so an older adult is probably highly likely to cut back on their food and fluid intake. And that there's a couple of things right there that are really, really important to coach people about. So the first has to do with staying well hydrated. And, just as a reminder, hydration is a day-to-day thing, really an hour-to-hour thing. Keeping well hydrated requires, recurrent and regular ingestion of fluids. Whereas from, a nutritional point of view, we've all not eaten well on a day or two, or fasted on purpose, or gone on a very strict diet. And that it doesn't upend you quite the same way that getting dehydrated can in the short run. So the first order of business is to make sure that people are coached to, drink lots of fluids, especially if they have a fever. Whenever somebody gets an illness that might cause any respiratory, an elevation in their respiratory rate, or a fever that increases their metabolic rate, they do lose more water through natural processes, through, breathing and sweating, obviously. And so they actually have a higher intake need of fluids to begin with. So I oftentimes will recommend that, having Pedialyte or Gatorade or something that they enjoy drinking, that they can tolerate, and to, almost take it like a prescription, and to continue to keep themselves well hydrated throughout the illness. And then the second thing is nutrition. One of the things that we've learned about the role of the change in taste, and therefore nutritional intake, that older adults have, is that in many, many places that decreases their muscle mass. It also, since they're probably not as active when they're not feeling at the top of their game, they're probably not exercising, informally, just by moving around as much. And so people are actually losing more muscle mass. And, there's kind of a rule of thumb that we keep in the back of our minds in geriatric medicine, that, every day an older person is at complete rest, that, they lose 1 to 3% of their muscle mass, and that 70% of that loss is below the waist. So then when they get up to try to walk or something, given any of the other medical problems that they might have, they're at a higher risk for falling. And so we have seen an increase in falls, both in the community and in long-term residential and care settings, in older adults that are moving through the COVID virus. And so it's important to try to find things that people will either tolerate or almost take as a prescription. Like you must eat adequately, even if it doesn't taste great. It's really, really important to prevent falling. And then the next thing kind of that we think about is, whether people should continue to take their medications or not. And I would say that for, most folks, that we do recommend that if they're eating and drinking decently, that they do continue to take their regular medications. And if anything, we want to monitor them more closely during the period of time that they're at highest risk, which would be, for the next week to 10 days after they begin having symptoms from the COVID virus. So we will try to make sure that people have blood pressure cuffs in their home. We want them to have thermometers in the home to be able to keep track of their temperature. If possible, we'd like to have them have pulse oximeters in their home, and have somebody teach them quickly how to use those devices. If you're affiliated with a practice that can provide remote patient monitoring, it's really any of these devices that I just described, but rather than having to write down the results from the measurements that are done are digitally transmitted, usually through Bluetooth devices that are very easy to set up in a person's home. And, for many of the patients that we take care of, they already are doing this because, having heart failure or having blood pressure, essential hypertension, measuring their blood pressure on a somewhat regular basis is something that we've already been training them to do. So we just amp it up a little bit and get them to do it a little bit more regularly if they're stable enough and don't need additional help in the house to make that happen. For those people that we care for that are functionally impaired to the point where they might need more assistance in the home just for ADLs and IADLs, that we try to partner up with who's ever in their home to help provide, remind them to take these readings and to do these readings and to kind of keep an eye out to make sure that they're doing it properly. And then they're either digitally coming to our practice or we're calling them up to check to see what the results are over the course of the illness. We definitely recommend and try to get everyone a small battery operated pulse oximeter to use on a regular basis. And I wanted to, in addition to just seeing what the pulse oximeter readings are, we also at that point want to talk to people and teach them, about measuring a respiratory rate, if that is something that they can absorb and kind of do properly, because we want to know before the oxygen saturation goes down that in order to maintain a decent oxygen saturation, they actually have increased their respiratory rate above normal. And then that kind of begs the question, like, what is normal? So of course, normal is whatever it is for the individual at baseline, but generally speaking, normal is not a respiratory rate of 20, which is for some reason something that is believed in most long-term care nursing facilities. But actually that is a slightly increased respiratory rate, and normal for, most people in their older years is, maybe somewhere between 12 and 16 or something like that, if they're not trying to exert themselves. So that would be the first clue that they're starting to develop respiratory distress, if their respiratory rate starts going up. And that'll happen before their oxygen saturation actually changes on the pulse ox. So if one can do that teaching, that is a good thing to monitor and to have a report come in to the providers that are taking care of the patient if it goes above a certain level, which you will set for each individual based upon their baseline. It's important for people to feel that they will be on an antipyretic. So if they're having fevers, giving them Tylenol within the safe limitations of taking Tylenol is really important to get them through that febrile period while they have the virus, so that they are less likely to lose as much fluid because their temperature is down. And it does help in managing some of the aches and pains that cause people to be more listless and less mobile, and putting them at higher risk for falling after being fairly inactive for several days. All of this is in kind of pre-introduction to, like, these are the things that we think about to get in place when we learn that somebody has COVID symptoms and that they're beginning to not feel well. But actually, one of the things about COVID-19 and its fairly rapid spread through most of our communities, and especially now during the winter, is that this has actually redoubled our efforts to talk to people about advanced care planning. So the thing is that, severe illness with COVID-19 can be, as I said, it's not a death sentence to get COVID when you're elderly, but, rightfully people understand that they have a higher likelihood of getting severe disease and needing really intensive treatment, and that those treatments may not enable them to get back to life as they knew it before they had come in contact with the virus, and it may not permit them to actually make it through the illness at all. So and then when you couple that with the fact that hospitals are at surge times, and we're kind of entering a period of surge, are rationing care, and they're trying to build out their capacity. But in rationing care, they may be less enthusiastic about admitting somebody who has COVID and is an older adult and is having some symptoms. There may just be not a lot of room at the inn in the communities in which you serve. And we certainly saw that in the March, April, May period of time in some of the heavier hit parts of the country back then. And my guess is that though we're better prepared, we may be facing, hospital bed rationing once again. And certainly ICU bed rationing is, we're really on the edge of totally utilizing all of the intensive care unit beds. There are a lot of places that are developing field or putting up field hospitals again. And so that's just an indication of, the fact that we're moving back towards that potential where rationing of resources might be occurring. And it's really important to be having conversations with older adults, and especially before they get COVID, but also as they have COVID, just to kind of have this conversation about what might be before them and what their wishes might be, and all of that. So fluids are really important. Antipyretics are really important for comfort and temperature. Monitoring a person's respiratory status, making sure that they keep moving, which is a good motto to follow in life. And then I think that, a really, really complicated part of this equation for community-based care is partnering with community-based services. So that includes a whole spectrum of different kinds of organizations in our healthcare delivery system. And it includes, being in close touch with people who provide social support services and IADL and ADL support services for older adults, and for lower income older adults, that's usually done through AAAs, and for older adults who have more financial resources, they have to usually buy those resources privately unless they have long-term care insurance, which provides some of it, or now sometimes MA plans are, kind of pitching in a little bit with some home-based nursing assistant care. But it's important to, get out in front of it and actually develop those relationships and game plans, and make sure that you share your cell phone number and their cell phone number so that you can make referrals as things change for people fairly quickly. And another part of this equation could potentially be, what about oxygen companies? And so we all know from our experience as providers in the community that under normal circumstances, there's not an insignificant delay between somebody qualifying for home oxygen therapy and it actually being delivered to their home. But for people who are experiencing the virus and who are making becoming more symptomatic from a respiratory perspective, there really isn't a lot of time. So, it's really, really important. What we do is we keep checking with our oxygen companies to make sure that we know exactly what they need from us in order to get out there, how much resource they have and availability they have to deliver oxygen to people who need it. And, for people who are not going to be hospitalized, keeping them comfortable at home, oxygen is a really, really important part of that equation if they're having respiratory symptoms. Getting them nursing assistance, as I said, is also really important. And then another partner is the visiting nursing associations. Home health can be an important partner in helping to manage and monitor the needs of people who are moving through the COVID infection themselves in the community, and they may need some skilled services from, if they're not moving, they might develop wounds. If they're getting weaker, they might need the therapies. If they have complicated medication management issues, they might need help from visiting nurses for that. And then with many of the home health agencies, but sometimes separate organizations, provide hospice care. So that's another important local partner to be in regular touch with, especially now, to make sure that we all understand who has the bandwidth to take care of people in their homes and to bring them into a hospice program should they elect to go in that direction, and provide them with the palliative care that they need as they're making their way through the virus. And I know that a lot of the rules around documentation and requirements for being in these programs are a little bit different, the way that they're interpreted from state to state. But I would say reaching out on a regular basis to know and understand the bandwidth and the availability, and develop that close clinical partnership can only be helpful when you find that there's somebody that needs that kind of assistance and chooses that kind of care. So moving on from that, so we talked a little bit about the equipment that you would try to get in someone's home, some of the community services. I hope I didn't leave any important one out. We talked about fluid management and nutrition and keeping moving. And I'm going to get a little bit medical now. We talked about advanced care planning and having those important conversations. And I'm going to get a little bit medical now and just kind of talk a little bit about some of the other things that might be helpful for people to have. So for people who have underlying history of asthma or emphysema or chronic bronchitis, it was felt that using inhalers was not a really good thing because some of the aerosol went into the air in the room, and if they had COVID, they were going to be spreading COVID. But it's now being recommended for those people to try to use a metered dose inhaler, and you could use a metered dose inhaler with a delivery system. But if all else failed, they're now approving the potential use of nebulizers in the home for people who can't manage that. It's not unreasonable to do that. And what one needs to do, like if the visiting nurse was involved in helping people set up nebulizer treatments in their home, to get through this virus, that they would teach them how to do it or teach someone in their family how to set it up. And that person would be alone in the room. The person who is using the nebulizer would have to be alone in the room with the doors closed. And, after they were done with their nebulizer treatment and the machine was turned off, one would then wipe down the surfaces with a disinfectant to make sure that there was no risk to others being in the room. The other thing that happens not infrequently, which is very disturbing to people, is in addition to having respiratory problems, they also develop a non-productive cough, and the cough can be uncomfortable. And so, treating them with cough suppressants and expectorants is something to consider. And, most of them are over-the-counter preparations and can be brought in the home. And, I would recommend that people have that along with their Gatorade or Pedialyte and their Tylenol or Advil or whatever they're using. When it comes to, we've learned that a lot of people who have a more progressive form, and actually sometimes even people who don't get that severe an illness, that they start developing a tendency towards blood clotting. There's been no evidence that actually doing anything more than keeping people moving, which is good for their muscles, as well as reducing the risk of them developing clots while they are getting through the illness, is in order. So making sure that people, are encouraged, urged, cajoled, and maybe sometimes even forced to go on a walk within their home with somebody safely on a regular basis is not only helpful to prevent or reduce the risk of falling, but it's also helpful in reducing the risk of thrombosis. So aspirin is not recommended. Aspirin use is not recommended. Low molecular weight heparin is not recommended to be given in the home at this point in time for people who are being treated in the community. And, so we wouldn't be ordering that. I also wanted to kind of put a kibosh on some of the other theories about things that might work that people have tried that don't seem to have panned out from the studies. And that includes the use of hydroxychloroquine. There was a person who had promoted the use of hydroxychloroquine at one point in time, but it turned out that actually that was not of any clinical benefit, and it actually was associated with an increase in adverse events in people with COVID-19 infections. There's been no evidence that vitamin supplementation actually helps at this point in time in community-based care of COVID. And then, there's been other outpatient medications like Zithromax had been touted to be used, and it turned out in studies that that was not useful either. I think that one important thing in thinking about, what we're facing with COVID is that while it's not apparent yet, there may be a increase in influenza that is going to be circulating. And so it's really, really important to make sure that everybody who is an older adult is up to date on their pneumonia vaccines, they're up to date on their flu vaccines, and as soon as they can, they should be given their COVID vaccine, but they can't get the COVID vaccine while they're sick. For people who are on other medications, generally each person, you need to be talking with the physician. And if anybody in the audience is part of a home health agency and is an RN visiting nurse, helping with medication management. You know, everything that was part of the person's regimen should be re-reviewed with the prescribing physician or the authorizing physician, and the care plan should be reassessed regarding every other medication that a person takes when they are moving through COVID-19. Let's see, what else could I mention? Obviously, all of us who are going to be serving these people who are being treated in the community, we have to have adequate PPE, and we should be, you know, doubly careful about donning and doffing full PPE when we go to visit them. This should not be a reason for people to not receive the care that they need, but we have to be careful as healthcare essential workers to provide them with the care that they need safely. Whenever we're in or around them, they should be wearing masks themselves, and we should be doing a lot of the usual distancing when it's possible, wearing full PPE, disinfecting surfaces, and you know, doing our own hand washing, as well as having them do their hand washing frequently. So I think I'm gonna stop there because it's about 20 minutes of. I hope I have covered a lot of the things that might have been on people's minds. And maybe we can have a long, I mean, this is almost the amount of time that I thought would be good to have a Q&A. Dr. Brown, why don't we go to that?
Sounds like a great plan, Dr. Abrams. So everybody, thank you for sharing a lot about your background in the chat. Now it's time to share your questions for Dr. Abrams in the Q&A icon at the bottom of your screen, at the bottom of your Zoom screen. So we look forward to your questions. I really enjoy the mix of attendees. We have everyone from CNAs, caregivers, nurses, social workers. It's a really great group, actually.
Yeah. There was something in there for everybody too. The rehab manager, the RNs,
Absolutely.
just by chance, the CNAs.
UMBC students, I love it. Dr. Abrams, I'm going to ask you a question that came up in a previous webinar that had to do with the evidence around blood type and whether or not people with certain blood types are more or less likely to get COVID.
Mm-hmm. So yeah, there is some evidence that certain blood types seem to be a little bit more protective in actually getting the infection. However, I'm going to quote my dear father, who always said to us as we were growing up, no matter what the statistics are, if it happens to you, it's 100%. So, you know, people are less likely to get it. It doesn't mean that they won't get it. It just means that if you have certain blood types that, you know, as a huge population, that there's a slightly lower incidence of infection. But I don't think that any particular blood type is totally protective against getting infected. So it's an interesting population health phenomenon, and yet I don't think it really has a lot of practical ramifications for each individual person in the real world.
That makes sense. All right, the questions are coming in. We have a question in the chat, and everybody please put your questions in the Q&A if you can. So working with my support group, should I encourage them to get a prep kit ready with the things that you mentioned they should have? So Ben, what kind of support group are you talking about? And while Ben is answering that, let's move on to the next one. What is your standard PPE recommendation when a patient or client has no obvious symptoms at an in-home visit?
I would say that if somebody is living in a community setting, or where, in a residence where they're in regular interaction with a lot of people, I would assume that everybody has it, even though we might not have tested them and proven it. So as far as PPE goes, obviously gloves. If you're, providing personal care, a gown, and a mask and eye protection is what's recommended. If you're not providing hands-on care and you can be more than 6 feet away from somebody, then you don't need all of that paraphernalia. You just need, basically the mask and the gloves if you're going to be touching any surfaces, or just, be careful to keep your hands to yourself and then wash your hands. But if you're going to be in close contact with somebody, you should assume that they are COVID positive until proven otherwise, even if they're asymptomatic.
That's great advice. So the questions are pouring in. Let's fly through them. I heard you say that people need to be on the move. What do you recommend if the person is short of oxygen? In this case, what must the person do?
So if they're short of breath, so I think if somebody is if somebody's short of breath, the first thing to do is, the first thing to do is to help them feel less short of breath. And then, if they need oxygen and oxygen helps them, or if they need an inhaler and oxygen, or just an inhaler and that helps them, at the point where they're not very short of breath, actually, really just getting up and down, standing up and down is the beginning of it. Exercise, walking them around their home a little bit would be another, kind of exercise. And, with all things, we don't want the perfect to be the enemy of the good. So, a little bit is better than none, as the person who's from the rehab would probably agree. And, if you could make it into a regular routine that's not exhausting, you can do a little bit a couple of times a day. The basic issues are that, both for the sake of reducing the likelihood of blood clots developing, and for reducing the risk of muscle loss, mostly in the lower extremity, having people use their muscles is really important to keeping them in tone and in shape, and as close to high functioning as possible.
Dr. Abrams, there's a chance that the person who wrote this also meant hypoxic when she said short of oxygen. So in the case that the person has a pulse oximeter reading where they're hypoxic, does your advice stay the same?
So oftentimes here's the thing, when people kind of go from having a normal oxygen level to being hypoxic, which is a low oxygen level, there's kind of two trajectories. People can turn very quickly with COVID and go downhill very fast. So I would say, in backing up, remember I emphasized reintroducing advanced care planning conversations. Like, if you get this virus and if it starts, kind of having an impact on your breathing, and if the hospitals are full, and if, and, it's kind of like, what do you want us to do? Once they have a low oxygen level, they qualify for home oxygen. If there is a supply available, and if the oxygen company that delivers that supply has the personnel and, isn't backed up to be able to get them oxygen in a reasonable period of time, the same thing would be true about using inhalers. If possible, getting their physician to order inhalers if they don't have them. The person who asked about, should I have a kit available? I think that it's not unreasonable to have a kit available. I think it's sometimes difficult to kind of get ahead of things like that with all of the people that your different organizations care for and care about. but I think it would not be a bad thing to have that kit. To me, it's like going on a long sailing trip and, not bringing an antibiotic along, so, you want to bring something in case you cut yourself and get a wound in the hot sun. So being prepared is probably worthwhile. I hope I answered the question about the low oxygen level. That would be the trigger to get oxygen and or inhaler treatments.
No, I think that's great. You answered that question, and you also answered Ben's question. He was talking about his Alzheimer's support group, and that's great advice. So moving on to Robin Udell, are there any thoughts about how senior communities may change their policies regarding outside caregivers coming in? What are best practices for testing these caregivers?
Yeah, so this is really a very, very difficult public health issue. So I noticed that somebody is a public health professional, that's listening in. I don't know if they're still here, but this is a really difficult call. So one thing that I did want to point out is that it doesn't make a lot of medical sense to require providers to actually be tested every week or every 2 weeks, because the virus, you could have just been exposed to the virus, test negative, and then 3 days later be an asymptomatic carrier. However, I think a lot of assisted living facilities are implementing these kinds of guidelines for their employees because it's more reassuring to the residents and their families. So unless you're going to be tested every day, it doesn't really make a lot of sense to test periodically. However, schools are now beginning to do things like, test the sewage supply to, like doing population-based testing to see whether there is COVID in that community might help target when you need to do it. And then I want to kind of cover the second piece, which is that, a lot of external providers provide care in assisted living facilities. That's really critical. So you basically have a group of people who are using PPE who can tell you that they don't have symptoms and pass the temperature test as they walk in the building. And yet several organizations are requiring that they also prove that they had a negative test within a certain period of time, which again doesn't make scientific sense, but for some reason is felt to be reassuring. And I've never quite been able to get my head around that, except that it could be reassuring, like, well, we're going to let your doctor see you in your apartment today. And by the way, they were negative 3 days ago. So that's a little bit reassuring, but keeping people from seeing their clinicians, I think, is at least as dangerous as, and seeing their nurses, their external nurses, and seeing their hospice providers, and and rehab specialists while we're going through this period of time, is equally dangerous. I do think that everybody needs to wear PPE and needs to be screened for symptoms. And we all need to be really honest about how we're feeling and to not put people at risk if we think we have a cold, because we don't know what a cold is anymore.
Along those lines, Dr. Abrams, first of all, just to be devil's advocate, one benefit of testing is the value of a positive test. And so knowing that your test is positive, the accuracy of the positive test is great for identifying people who can quarantine and keep themselves away from other people. But you're right, the negative test doesn't really mean anything. How insistent should we be that our older clients wear a mask if they already have breathing issues? I have a very strong opinion about that. What's your opinion, Dr. Abrams?
Well, it really all depends what you mean if they have breathing issues. So we all have, there are a lot of people who have trouble wearing a mask. I guess the real thing is to figure out whether it's psychological or physiologic. And you could find that out if you use their pulse oximeter. And I would say that, it's not unreasonable that people would have kind of fear of things being put over their nose and mouth for lots of reasons. That you are actually breathing your own breath when you have a mask on, which is not always that comfortable a thing. But I would encourage people to do it. And I would say for those who really can't do it, and I'm trying to engender their cooperation, I will step away and I will let them pull down their mask and take a couple of breaths. But I would also say that it's okay to refuse to see somebody who won't wear a mask and protect you.
Excellent answer. I agree with that. So we're flying through the questions. We have a couple more. There's a question about boosting immune systems. I don't see much reporting in the news about prevention with regard to boosting our immune systems. Are there things that we can do to boost our immune systems or that we can educate our patients with?
I have to plead ignorance on that one. Aside from, living well and eating well and exercising, and, I'm not, I would say that there's no evidence that like taking high doses of vitamin C or anything like that there's no evidence. I'm not saying that it doesn't work. I'm just saying there's no evidence that any of those things work in reducing the risk of severe disease or getting the disease or whatever. So one thing that I did want to just explain is that, you could have a really great immune system, but this virus, your immune system has never, ever seen. And the way that the body works is that when you get exposed to a new pathogen, a new disease-causing entity, it takes your body a little while to start developing the immune response. And the immune response is not always that robust. And so, I'm not sure, maybe you could do a little bit better if you happen to have one of those immune systems that was a little bit more reactive to a foreign invader. Older people tend to have a more sluggish immune response to everything. So that's part of what puts them at higher risk.
Absolutely. And I think it's important to underscore what you said about there's no evidence that supports that. So we have a couple of questions that I suspect you're not the right person to answer, but I'll ask them anyway. Do you have any information on the state of Maryland's plan for immunizing frontline workers?
On which plan?
Dr. Abrams is based in Massachusetts, but the question is about information on Maryland's plan for immunizing frontline workers. Perhaps you have some insights from Massachusetts about how they're approaching the immunization of frontline workers.
Well, I can tell you about the way the process works here, which might be somewhat similar to what's happening in Maryland, which I'm not aware of. Mm-hmm. So in Massachusetts, all healthcare providers need to actually sign themselves up on an immunization website, a Massachusetts immunization website. And there's a lot of information about how you practice, where you practice, who, your patient panel, et cetera, And then based on that, you're either going to be in group 1A or 1B or 1C, and that is kind of being developed as we speak, although hospital-based workers and people who are healthcare workers in nursing homes are already beginning to get their first dose of vaccine as of yesterday. So, they're definitely in the first group. And as a community-based practitioner, I'm not in the first group, and I haven't heard which group I'm in, but I think it will be, probably after all the hospital and ED and urgent care centers, where people come in contact with people somewhat randomly, they'll probably get it before those of us in primary care practice.
Great. And to answer, thank you, Dr. Abrams, to answer Donna Chambers' question about whether or not we'll get a handout, this webinar is being recorded and the recording will be available online. Everyone who registered and is attending the webinar will get an email with a link to that recording. I think that's it. My goodness, that was so interesting. Oh, no, one more. Okay, when a person, oh my goodness. When a person has trouble breathing, can they, this might be something, when a person has trouble breathing, can the inhaler be combined with oxygen? This might be a question that is so specific that I'm not sure that you can answer it, but Doc, I'll leave that.
Just to explain to the group, yeah, I think it's easy to say that when a person has trouble breathing, inhaler treatments happen, oxygen can happen. They can take an inhaler while they're on oxygen. There's no contraindication to doing that. It's just, logistically, it might be difficult for them because they either have to have an oxygen mask or they have to have prongs up their nose in order to deliver the oxygen. And they may have to, kind of curtail that for the very brief time that they would be using an inhaler. So remember, an inhaler is 2 quick sprays that they inhale in a synchronous way. And, then they would put their oxygen back on right away. And the medication would continue to work in their lungs for a while to keep their airways open.
Fantastic. Thank you, Dr. Abrams, for this wonderful, wonderful, wonderful presentation. We will definitely, there's a couple of people asking for links to the recording. Again, if you registered, you'll get a link. We've even gotten some emails in the Q&A. We will make sure to get the information to you about Dr. Abrams' outstanding presentation. Dr. Abrams, that's a compliment to you, how many people are clamoring for your presentation. And so we will make sure that that is distributed. Let's just close out with another round of thank yous for the Maryland Emergency Preparedness Network, the Maryland National Capital Home Care Association, the Maryland Department of Health, and all of you for your outstanding, outstanding questions. Many of the questions today were medical in nature, so don't forget that Dr. Abrams is not clinically seeing you or your clients, and to be sure to get the kind of clinical and medical advice you need for the specific clinical situations that you are encountering. That's called the disclaimer. Have a wonderful rest of your day, everybody. Be safe and stay well. Join us on Monday.
Yeah.
Did you have a final thought, Dr. Abrams?
Just happy holidays to everyone. Hope you can have decent holidays.
Yes, happy holidays to everyone. But before the holidays, we have 3 more webinars. We're packing them in. Thursday, December 7th, Monday, December 21, you can see me. And on Tuesday, December 22nd, we're closing it out with a bunch of CNAs who have a CNA talk show. So we'll see you all then. Thank you, Dr. Abrams.
Bye-bye.
Bye, everybody.